Welcome, everyone. My name is Mark Johnson. I'm a volunteer with the Canadian Celiac Association, and I'll be your host today. I'm fortunate to be joined by Dr. Maria Ines Pinto-Sanchez, who serves on the Professional Advisory Council of the Canadian Celiac Association. Dr. Pinto-Sanchez obtained her MD certification in 2002, and she completed her gastroenterology training in 2008 at the Gastroenterology Hospital in Buenos Aires, Argentina. She obtained a Master in Science degree in 2014 and is currently an assistant professor at the Gastroenterology Division at McMaster University in Hamilton. She's also the current director of the Celiac Clinic at McMaster University. Her clinical and research interests include the diagnosis and treatment of different gastroenterological conditions with a focus on celiac disease and gluten-related disorders. Welcome, Dr. Pinto-Sanchez. Thanks for joining us.
Thank you so much, Mark, and the Canadian Celiac Association for having me today and doing this fantastic event and educational event. That's great.
Thank you. Now, this is one of our In Conversation series installments for you on matters relating to celiac disease and the gluten-free diet. Every other month, we bring these to you as part of our CCA Connect newsletter. We've been talking to leaders and change makers in the gluten-free industry, research field, medical professionals, stakeholders, and more. We hope that you'll listen and learn, and you're invited to share your thoughts on potential guests with us. You can email us at communications@celiac.ca with any ideas. But today we are talking about non-responsive celiac disease, and in particular, the lesser known condition of refractory celiac disease. So Dr. Pinto-Sanchez, I was wondering if you could start with, what is non-responsive celiac disease? Is this the same as refractory celiac disease?
So thank you, Mark, for that question. You know, this is a question that many of my patients ask when they come to see me. And non-responsive celiac is a condition where people with celiac disease that are attempting a strict gluten-free diet, they think that they are doing the diet very good, they persist with symptoms that are mainly or mostly linked to celiac disease. For example, a person that has been doing a gluten-free diet for almost a year and still has abdominal pain, discomfort, diarrhea, constipation, and there is no anticipating reason for that. So this is a person that has a non-responsive celiac. But as you will suspect, those symptoms are quite non-specific, and that's why the non-responsive celiac is a kind of a big umbrella that involves so many different conditions, including refractory celiac disease. And refractory celiac disease is one of the very rare condition part of the non-responsive. But in refractory celiac, the difference is that we are not just seeing symptoms related to celiac disease, but what we are seeing is the celiac disease is quite active. And we don't know why, because that person is doing a gluten-free diet. So it's not just that the person is not responding symptomatically, is that that person is not responding, the inflammation in the gut is not responding to the gluten-free diet. And this is a different condition, it's a little bit more serious condition than non-responsive celiac.
So when people say that they are feeling ill still despite being on a strict gluten-free diet, it's not just about the symptoms. The villi are still being damaged, destroyed in the small intestine with refractory celiac disease?
That's correct. That's the difference, because the non-responsive celiac, which includes the refractory, sometimes people with non-responsive celiac, they can have other situations leading to mild inflammation, but in most of the cases, when celiac disease is treated with a gluten-free diet, in most of the cases, you should see an improvement in the inflammation or a response to gluten-free diet, right? Mm-hmm. And when someone persists with symptoms, then we are thinking that they may not be responding for different reasons. For example, someone can be responding to gluten-free diet, but they may have still diarrhea because they have bacterial overgrowth, or because the pancreas is not working properly and they may need some digestive enzymes, or because they may have additional overlap, a functional condition similar to IBS, for example, right? So there are so many different reasons that could lead to lack of response in symptoms. But when the gut is still severely inflamed, like despite doing a very strict gluten-free diet, then this is when we start thinking and investigating for refractory celiac.
So complicated. Even the symptoms for celiac disease are so varied, and the symptoms for non-responsive celiac disease can also be varied. As many as you know, Dr. Pinto-Sanchez, and many of you out there are part of it, the CCA has a very active and large Facebook group. I see many people reporting that like they're still suffering symptoms. I'm on a strict diet. I'm very, very careful. I still feel terrible. They wonder whether they might have non-responsive celiac disease or refractory celiac disease in particular. Myself, for example, 16 years after a biopsy diagnosis of celiac disease, I'm still lactose intolerant. I suffer from ongoing acid reflux. These are just two possible symptoms. There's a whole range that others experience. So when people jump to the conclusion and think, well, maybe I have this condition, can you confirm how frequent refractory celiac disease is?
Yes. So the good thing is that refractory celiac, like a true refractory celiac, is quite debilitating condition, but is very infrequent. It's only 1% of celiac patients or less than that will have what is called refractory celiac. And if we consider from the whole population of people that persist with symptoms and then non-responding to the gluten-free diet, the non-responsive celiac, it will be around less than 10% of them, right? So if you're not responding to gluten-free diet properly, let's say that you still have symptoms despite adhering or thinking that you're adhering to the gluten-free diet strictly, the most likely is that you don't have refractory, that you have other situations that are maybe explaining your symptoms, right? It will be very rare to have a truly refractory celiac not responding at all to the gluten-free diet.
You mentioned people, sorry?
No, actually, I wanted to comment that the non-responsive, so from the whole population of celiac, 50-60% of people with celiac, they will do very well with the diet. And the symptoms will completely improve and the gut will heal. But in 40 or up to 60, depending on the situation of the cases, people still have some symptoms persistent, right? Despite gluten-free diet, especially in the first year. And it's quite common that the most common reason for that is because there is unaware persistent exposure to gluten. That is very, very common, right? So you're thinking that you're doing the diet very strictly, but you didn't know that there was gluten hidden somewhere else, for example, you know, like or suddenly gluten was a food component that you was eating every day was recalled, right? And you didn't know that contained gluten. So these situations happen very frequently, and that explains most of the cases. But having truly refractory is very, very few cases that you will see, and it's very rare to find within celiac population.
You exactly addressed the question I was thinking of there when you mentioned people think they're following the strict gluten-free diet. So like, do you see frequently people coming into your clinic saying, I was celiac for a year, I've been celiac for a year, I've been on the diet very strictly, I probably have refractory celiac disease, but then you find out, well, actually, you've been going to this restaurant, maybe you should check on that, or you've been eating this product, maybe you should read the label on that. Is this a common occurrence you find?
This is very common, and particularly because when a person is diagnosed with celiac disease, not everyone has the opportunity to see a dietitian and have a complete education on how to prevent this situation of cross-contamination or getting unaware gluten exposure, right? So especially in the first year, when someone is getting familiar with the diet and then getting all the knowledge related to that is required to follow a strict gluten-free diet, is quite common that people can be exposed to gluten and are not aware of that. So we see most of our patients with non-responsive celiac in the clinic. When they meet with our dietitian, they go to a 45-minute or whole hour session reviewing their diet, and then sometimes identify situations that they didn't know that could expose them to gluten.
I think that's an important takeaway, that if people are still suffering symptoms, you know, perhaps before jumping to the conclusion, I need to see specialists, I need to go back to the gastroenterologist, I need all these tests, like maybe first it's one of what the CCA recommends for newly diagnosed celiacs. Please see like a knowledgeable registered dietitian and go through a session to make sure you've eliminated all the gluten from your diet. You have one at the Celiac Clinic there. I know we have Nicole Byram with the Canadian Celiac Association too. So it's an important step to your gluten-free journey is sitting down with a registered dietitian and trying to prevent this the ongoing suffering of symptoms, right?
Absolutely, absolutely.
Mm-hmm.
Actually, we work very close, in our clinic with dietitians. But again, it's very, very important as part of the journey to get, like the help or education. And the Canadian Celiac Association also, we always recommend our patients go to to their website, check all the information, because you have fantastic information on ways of how to prevent resources, handouts on how to prevent cross-contamination. And it's a matter of education, and it takes time. It takes time to get used to all these aspects that one needs to take into account to prevent contamination with gluten.
Mm-hmm. Yeah, like I said, I'm 16 years in, and I'm still reading every label. You never know when gluten might pop up in certain products that you were used to. So also, like you've mentioned about how many of these patients are still inadvertently getting exposed to gluten. But to get back to refractory celiac disease, which is definitely a very real, very serious condition, we know, I know over the past decades, we've seen an increase in the incidence of celiac disease in the general population. Are we also seeing that same increase in the incidence of refractory celiac disease relative to the total population?
So the studies on prevalence of refractory celiac disease, they have not been truly updated, but it is expected that if we are seeing an increase in incidence of celiac disease, that we will have an increase on the prevalence of refractory celiac disease, absolutely. But the studies on prevalence are very, right now they are not updated more recently as far as the prevalence of celiac disease has been updated, right?
Okay, still a work in progress.
Yeah.
I know. So one of the major challenges in celiac disease, we talked about the symptoms. It's so difficult to diagnose. It could be pretty much anything. I had the gastrointestinal symptoms. I was just chatting with another longtime volunteer. Her symptom was completely just dermatitis herpetiformis. Last weekend, I met another celiac who had no symptoms at all apart from low iron. It was really just an accident that he was diagnosed with celiac disease. He was a silent celiac. And there are many other symptoms, the brain fog, chronic fatigue, osteopenia, depression, infertility, I can go on and on. Is there a specific set of symptoms that tends to be tied to refractory celiac disease, or is it really could be anything?
Right. So that's a good question, because once we define refractory celiac, and we need to, the area that is most affected is the gut, right? So the gut is very inflamed despite adhering to gluten-free diet. So consequently, people will have mostly malabsorptive symptoms. What that means? It means that people will have very likely diarrhea, and a diarrhea that doesn't resolve with regular medications. And they will have abdominal bloating, pain, because they are not absorbing proper nutrients. And they will have very much more likely they will need additional nutrition support because they are not absorbing the nutrients. So it's the symptoms are quite severe compared to a person that is non-responsive for other reasons. So very likely this person with refractory celiac will end up in hospital, right? They will end up requiring nutrition that sometimes they are medications that are not regularly given to celiac. They will require IV nutrition sometimes, so because they are not doing very well. This is most of the cases with refractory that are not well controlled. So the symptoms that a person with refractory celiac will have mostly are related to the malabsorption, so diarrhea, weight loss, right, bloating, and then they will become very weak because they will not be absorbing the nutrients as they should.
Yeah, we know once you go on the gluten-free diet, a lot of like those symptoms should resolve. So if they are not, then there's definitely a problem, perhaps inadvertent gluten exposure for many too. So if it is refractory celiac disease, how does someone get officially diagnosed with that? Is there a test?
Unfortunately, there is no one single test to get diagnosis of refractory. What we need to, once we are seeing that the person is not responding to gluten-free diet, and then they are still persisting with malabsorptive symptoms, like say the diarrhea, they are losing weight despite adhering to the diet, and there is no other reason for that, right? So then we do the endoscopy. And when we see in the endoscopies that this person with refractory celiac, they will have the villi will be still atrophic, right? The shortening in the villi. We will see that's persistent, and there is quite inflammation there, still persistent as the person is not doing the diet. So, and then what we need to do, because one of the things that I didn't mention is that there are two different types of refractory celiac. One is described refractory type 1, and the other is described refractory type 2. And some people with refractory type 1, which is the relatively more common than the two, that type of refractory celiac, usually with Medicaid, usually the cells that we can investigate in the biopsies did not change too much compared to the regular celiac. So it's just what persists there is the shortening of the villi. But if you investigate the cells further, you do like a different staining test that are more like determined for these investigations. So you need to stain those cells. And those cells look similar to a person with celiac disease. However, the type 2 refractory celiac, this is a more severe type of celiac. And it's more severe because that inflammation led to those those cells to change. So then now the cells are not looking to celiac, they're looking more towards the complications, what is, they have changes that could lead eventually to development of cancer, right? So when the cells are changing there, then we are being more aggressive in terms of doing investigations, extra investigation with X-ray, CT scan, to see whether that person gets any complication or there is any other evidence of malignancy. So that's how serious can get very, very little proportion of patients with refractory celiac. But most of the cases, as I said, the refractory type 1 that looks similar to celiac, once we do is to determine whether this atrophy is just limited to the gut or there is inflammation somewhere else. And then we do different CT scans and we do different investigations to understand whether that's just limited to the gut, right? So endoscopy, CAT scans, we do the staining. So those are the type of the tests that we do in refractory celiac to understand better whether this person has refractory type 1 or type 2. And that's very important to proceed with, to understand how, or to predict how it's going to behave, right?
So I've read, so I think what you're basically saying is it's a diagnosis of exclusion. I know I've read that if everything else is ruled out, but they're suffering the symptoms and the intestinal damage, that's when you reach the conclusion that it might be refractory, and then you do the additional study of whether the cells have changed or not.
Exactly. So diagnosis of exclusion means that there is nothing else that is explaining what that person is not responding to the gluten-free diet. So there is no, persistent gluten, right? So you go very deep, you dig very deep in the diet. So you are excluding any contamination. You're excluding, and then sometimes what we do in our clinic to exclude contamination is to do a test to detect gluten, right? So you know that there is a test that detects gluten in the stool. So usually we recommend that. So once we exclude that and we exclude other conditions, for example, inflammatory bowel diseases, they can also lead to shortening the villi, right? So we can see that in the endoscopy. If we exclude that and we excluded other conditions that can lead to shortening of the villi and we cannot explain that, so then we think that this person is not responding and is a refractory celiac. And then this is when we do all the stainings, we do the CAT scan to to see whether that inflammation is limited to the gut or there are other areas affected.
You mentioned stool tests. I know we've years ago there was a phenomenon of stool tests being advertised as helping to diagnose celiac. We know that's not the case, but you can use stool tests to detect if someone is still eating gluten. That's what you're saying?
Right. So there is a test that is called that detect. It looks similar to a pregnancy test, but the target of that test is the specific parts of gluten that are called gluten immunogenic peptides. So those are the specific parts of gluten that will cause the reaction celiac. And you can detect that in stool. So if you have been eating gluten or have been exposed to gluten in the last 3-4 days and you didn't know that, let's say that you went to a restaurant and you didn't know even though you ordered for a gluten-free meal, but you don't know how that meal was cooked, and then you was exposed to gluten, you can do that test and detect the specific parts of digested gluten in the stool, and then you will know that you had a contamination with gluten, right?
Mm-hmm. Yeah. So and that if you do find that there's no gluten in the stool and everything else is ruled out, and you conclude that it probably is refractory celiac disease, I can see someone saying, well, look, the diet is really difficult to follow anyway. If I'm not healing, can I just eat gluten anyway if it's not gonna help? I assume that is a terrible idea. Could you explain why?
So I you assume right, because you imagine that how severely ill you are if you don't eat gluten. So you should imagine how bad it could be if you eat gluten on top of that. So if the gluten is, you know that in someone with celiac disease, gluten triggers an immune reaction, so a reaction in the body. So if you are removing that part and still your body is reacting, you can imagine if your body is reacting and then you bring gluten on the top of that. So the reaction increases, and then you will develop you will definitely get worse, right? So even what we call refractory to gluten-free diet, we still recommend that the person is doing a very, very strict gluten-free diet to prevent any other factor inducing this inflammation, right?
Yeah, and the gluten-free diet's still critical, but for folks with refractory celiac disease, it seems to not be enough. Are there any treatments available for refractory celiac disease that can offset this damage in the symptoms?
Yeah, so when the person is diagnosed with refractory, and that's why it's so important I focus in the way of diagnosis of refractory. There are many people that they are labeled as refractory, and sometimes they are not truly refractory, is that there are other, so that it's important to diagnose well. When a person is diagnosed with refractory, then the treatment on the top of the gluten-free diet is to give a medication that will suppress the immune system. Similar to people with inflammatory bowel diseases, they need steroids, they need immunosuppressants, they need biologics. There are other medications targeting specific proteins or molecules involving these reactions, or blocking those proteins to reduce the immune reaction seen in refractory. So in addition to the diet, it will be other intense medications like steroids, immunosuppressants, or other medications blocking immune reaction.
Thankful to hear there are options, and of course the number one treatment has to be continued strict adherence to the gluten-free diet. Do we know if there's any connection? Like, we know a lot of people with celiac disease have other autoimmune conditions as well, thyroid disease, type 1 diabetes, Graves' disease. There are many others. Any links that you found between refractory celiac disease and other autoimmune conditions?
So celiac disease, as you said, is associated with other autoimmune conditions, and there is no specific link seen, particularly in refractory, over the celiac disease. So all of them are related with other autoimmune. Once you have one autoimmune condition, then you are more prone to develop other autoimmune. But that's not necessarily specific for refractory. It happens in all celiac patients.
So if someone is not getting better after going gluten-free, could it be that they have another medical condition, another autoimmune disease, perhaps?
Absolutely. So that's why before diagnosis refractory celiac, we do like a battery of different tests to rule out any other conditions leading to what we call the non-responsive celiac, right? So someone that is not responding. So we do a lot of different tests to rule out other autoimmune, inflammatory bowel disease, problems with the pancreas, pancreatic insufficiency, bacterial overgrowth. We do different testings to make sure that there is nothing else, including other autoimmune. There could be other other inflammation in the gut that is particularly related to autoimmune condition that is different from celiac disease. So sometimes we do testings as well to make sure that there are no other autoimmune conditions inducing inflammation, right?
And I know you're, as a world-renowned researcher, I feel I can ask you this question. Celiacs, we're always curious about statistics and facts. I know some areas of the world seem to have higher incidence of celiac disease, like Finland is a well-known example. Do we know, are there areas of the world that have higher rates of refractory celiac disease as well?
So, right. So once you have an increased incidence of celiac disease, you have more people with refractory because it's a matter of statistics. But to be honest, the groups that have more incidence or have reported and studied more in refractory celiac disease have been, in Europe, in the Netherlands, in France, in Finland, in the US. They have in Argentina, actually, where I came from, there is interest, particular of monitoring and follow, and there are already studying refractory celiac. But as I said in the first answer, it's difficult to, all these prevalence studies are difficult to do because the disease is so rare, right? And it requires so much for like complexity for diagnosis that sometimes, sometimes it's not highly accurate, the numbers that you're going to get for the prevalence of this condition. So I think it's what we really need in order to improve the knowledge in refractory celiac is to get awareness that this could happen, and then when this happens and when the person is not responding, is to talk to a specialist, and then to do all these diagnoses to rule out other conditions and to have a proper diagnosis of refractory celiac. So that, I think, is very important. This is what it will give us a better idea of the incidence and the prevalence of the refractory.
You talked about the importance of awareness, so participating in this, our conversation series is a good step, so thank you again for that. For my last question, I'd like just to bring it home for folks who are watching, are you able to speak, I know about doctor-patient confidentiality, of course, but in a general sense, are you able to speak about any cases of refractory celiac disease that you've personally seen at the Celiac Clinic at McMaster?
Yes, absolutely. So at the Celiac Clinic at McMaster, we receive referrals for people with non-responsive celiac. And then, these are people that are struggling with symptoms for quite some time. But particularly, it came to my mind a patient of mine that developed refractory celiac from the beginning, right? So that are, in most of the cases, you will see refractory celiac in people who are on a gluten-free diet for some time, and then at some point in their life they stop responding, and then you do investigations and see that then the disease is active. But in these cases, that patient, they just develop a quite severe celiac disease that end up being hospitalized, requiring IV nutrition support, right? And then he has started the diet, she has started the diet, and nothing has happened in terms of improvement. It's not the typical improvement that we see in the first weeks or months. So then, in that case, in those cases, sometimes I know that for the definition is required that that we wait quite, with like 6 months to a year to start medication. But sometimes these cases are so complex and so are very, very, very sick that we need to start medication earlier on and do all these tests earlier on, right? Even before the 6 months. So it comes to my mind to these patients, and this is what I want to address. Is refractory is very, it's not something, it's not the normal behavior of a celiac patient that has been struggling with symptoms for a long time, and then they will see a response to gluten-free diet. And yes, some people may persist with symptoms, but in terms of refractory, these are people that are very, very ill, right? And then they end up in hospital requiring additional treatment, nutrition support. So it's a completely different panorama presentation compared to a person with celiac disease.
Well, it's reassuring to know how exceedingly rare this condition is, especially the type 2, and it's rare to such a degree that when you do have it, you become a subject of scientific study because it's so outside of the norm. So that's reassuring. It's very rare, and please stick to the gluten-free diet. So we've run out of time. I want to thank you very much, Dr. Pinto-Sanchez. We appreciate you sharing your insights and vast expertise with us. Thanks very much.
No problem. My pleasure.
And thanks all of you out there for joining us too. In terms of what's up and coming, I want to highlight very much for you the Canadian Celiac Association's free online conference coming up in November. Registration is open at www.celiac.ca. So it's a weekend event running on November 13th and November 14th. That's Saturday and Sunday. So we have two different streams to try to appeal to all of you out there. On Saturday, November 13th, it's going to be what we're calling the beginner celiac stream. So this is going to be more aimed for the newly diagnosed, but everyone can attend, of course. We'll talk about coping skills, managing isolation, some depression and anxiety that can result or might have been one of the symptoms. Things like dining out, how to travel safely gluten-free, not that that's a big thing right now, but celiacs often love to travel, and after post-COVID, we will. How to read a label, and an overview of some of the new information that's relevant for kids with celiac disease in particular. And then on the second day, on Sunday, November 14th, it's the intermediate to advanced celiac stream. So we're going to talk about the latest in scientific research, long-term coping skills and management of the diet, like diet fatigue, and like ongoing symptom management. What do you need to know? What do you need to do in the long term to manage your celiac disease as a seasoned celiac? So forgive the food reference there. So that's November 13th and 14th. Both days are going to run from 12 to 4:30 Eastern time. So that's flexible enough for all time zones and not too much out of your day. So again, you can register on celiac.ca, and we hope to see you there. You can watch your CCA Connects newsletter and celiac.ca for updates on the conference and our plans for the next In Conversation series installment and other news and events, of course. So thanks again for joining us for this. Bye for now.